Okay. Good afternoon, everybody. Oh, Good afternoon. So, as most of you know, I'm Paul Johnson. This is Annie Lynn. We're the chief residents here at UW, and also representatives of the graduating class. And you may also know that every year the graduating class gets to invite one resident invited speaker. And it was very important to our class this year that we chose somebody who was both well-respected physician scientist and also a leader in the neurology community. And for that reason, we are very pleased and excited to welcome Dr. Claudia Lucchinetti to Seattle. She is our resident invited speaker this year. Dr. Lucchinetti is a native of Chicago. She got her medical degree at Rush Medical College and then went to Mayo Clinic for both residency and fellowship, where she is now the chair of neurology. And Dr. Lucchinetti is a MS specialist who does quite a bit of research in the area of ADEM, NMO, and MS, including cortical lesions in MS. And we're very excited to welcome her here for her lecture for Grand Rounds. Thank you.
Turn on my microphone real quick. All right, well, first of all, thank you. I'm really honored to have been invited to, on behalf of the residents, and also congratulations to all the graduating residents. We just had our graduation last week, so I wish you all the best on your next stage in your journey. And as a neurologist who's always been kind of fascinated with trying to learn about these disorders through the microscope and trying to relate that back to patients, NMO has been an area that's really been informative, and just the amount of energy and excitement around understanding this disease is what I hope to kind of share with you today. So really take you from the path of what we've learned about this disease clinically, what studying it at the microscopic level has showed us, and how we can bring that to the patient at the bedside with various trials we're interested in, as well as into the lab at the bench to be able to study and understand what is really a unique opportunity to understand the role of astrocytes and aquaporin 4 in general in not only the nervous system but in the body in general. So that's kind of why I gave it this title, a systemic neuromyelitis optica, systemic autoimmune channelopathy. So there's a lot of content, but I'll kind of take it slow. A couple disclosures related to the discovery of NMIGG led by Vanda Lennon, and we were involved with Brian Weinschenker and I in that. And I do have some grant support from industry and DOD and MS Society. So just for this room, many of you already know that the core features of this disease, which is what we all focus on, as being a CNS inflammatory autoimmune disease. I deliberately took the word out, demyelinating, and I'll say why as we move along. But demyelination is really a secondary event. And the hallmark of the disease, as we all know, has historically been focused on the optic neuritis. And you can get these lesions involving even the entire chiasm or extensive in the optic nerve. And in addition to that, of course, are the classical longitudinally extensive lesions, or in the acute stage, where they can expand and extend beyond 3 intervertebral segments, something you really don't see ever in adult MS, but you may see that in childhood MS, so it's not a discriminator necessarily at that age. It has been said that the brain is often spared early, but I think that that's beginning to change a little bit, as we'll hear in my talk. Early on, it used to be mistaken for MS or severe MS, but of course, things have evolved since then. Back in early 2002, actually even before that, around 1999, I began looking at NMO lesions, and at that time was struck by just the unique astrocytic pathology of the disease. My notes would often say bizarre astrocytes, astrocytic disease. It was around that time that Brian Weinschenker was also looking at this disease clinically, and Vanda Lennon serologically, but we had described some hallmarks of this disease pathologically, and this is a spinal cord of an NMO patient, very destructive lesion involving the gray and the white matter. And I was struck in particular by the infiltrate of granulocytes, eosinophils and neutrophils, somewhat unique to NMO, not seen really in typical MS lesions. But more importantly was this pattern of immune complex deposition of IgG and IgM, and what I refer to as a rim and rosette pattern. Here you see the rosette and the rim of C9neo, a marker of terminal complement complex, on the abluminal, the outer surface of the vessel. And at that time, we proposed that this was a disease caused by a specific antibody targeting a perivascular antigen. So that was from the microscope. Let's talk a little bit about what we know different between MS and NMO. It tends to be older onset in NMO than MS, more likely a more robust female to male ratio. And importantly, both the diseases have a relapsing phenotype. However, a secondary progressive course is distinctly uncommon, almost unheard of in NMO, whereas that's really the hallmark of multiple sclerosis. The attack severity in NMO is so severe that it's the kind of patient you don't really wait when they call and say they've got a numb finger, you jump, because those are the kind of patients that quickly get worse. Whereas we might watch an MS attack and say, call me in a few days, let's see how it goes. Autoimmune disease is really much more common in NMO than MS. And the CSF is just different as well, with the more likely of seeing a pleocytosis, sometimes even hundreds of cells, with prominence of PMNs in the acute stage. We don't see oligoclonal bands as often. We talked about the MRI of the spine, and we'll get into the MRI of the brain a little bit later in my talk. But it became really important to distinguish these diseases. Epidemiologically, they're different. In contrast to MS, NMO is pretty common in non-whites and populations with minor European ancestry. And in fact, it's the typical form of so-called Demalian disease in Africa and Asia. And the genetic polymorphisms seen in MS are not associated with NMO. But we had to ask ourselves, why is it so important? Why should we care so much, and why did we? Well, the prognosis was quite distinct in NMO compared to MS, and it was recognized that treatments we use traditionally in MS could actually exacerbate NMO, particularly with respect to interferon beta 1b. It was really the work led by Vanda Lennon, and here's Brian Weinschenker as well, and we worked together with them to identify this autoantibody biomarker, which early on had shown a sensitivity of 73% and 91% specific. And what you see here is just an immunofluorescence where you have the antibody from the human labeled in green. This is mouse tissue, cerebellum, midbrain, smooth muscle, mucosa of the gut. And what you appreciate is there was a distinct vasculocentric pattern. It also stained the pia and the subpia, and it distinguished what was being referred to as opticospinal MS in Japan. We worked closely with the group out of Japan, Dr. Fujihara and the team, and we quickly recognized we were identifying the specific disease. Just bring your attention to the fact that when you take that same immunofluorescence and now also label with factor VIII, which labels the endothelial cells, note the antibody stains this adluminal surface out here, exactly where we saw that C9neo and that IgG deposition several years earlier. The test has evolved from immunofluorescence to really being able to highlight that the FACS assay is a much more effective assay. And what this basically says is right now we're at a sensitivity of about 76.7% on FACS, close to 100% specificity. And generally it's important to recognize there has been some variability in testing, but that's mainly the state of the art now is through the FACS assay, somewhat cell binding. We know that this antibody that you see in NMO can respond and drop in treatment. So like if a patient here who got rituximab, you can see how the antibody level drops. So that's one explanation why not all patients are positive. There's probably a subset of patients who may eventually become positive or may have a different antibody, and that's still an area of ongoing investigation. Unlike MS, which is often said to be the prototypic autoimmune disease, it's really NMO is the prototypic autoimmune disease. Here is a disease where non-organ specific autoantibodies, multi-system autoimmune diseases are frequently seen, pernicious anemia, ITP, other diseases like that. And then this whole story of lupus myelitis, Sjogren's myelitis, well, in a study led by Brian Weinschenker, when we found optic neuritis or longitudinally extensive transverse myelitis in NMO-IgG patients with Sjogren's or with lupus, we think it's a coexistence of the two diseases as opposed to Sjogren's myelitis, which would often be described before this antibody existed. In addition, a classic autoimmune disease in the periphery, myasthenia gravis, is actually more common in this disease. 11% prevalence of the muscle-acetylcholine receptor antibodies, and a 2% prevalence of myasthenia gravis in NMO. We've had several patients with both disorders. And interestingly, NMO-IgG can be associated with malignancy, and in fact, we're increasingly recognizing this association. So it's worth mentioning that when your patient, 65-year-old or older, is presenting with neuromyelitis optica, a malignancy screen is worth considering doing. We've found a number of malignancies, several of which express aquaporin 4 within the tumor. So we suspect there's a paraneoplastic immune response involved as well in a subset of patients. The antibody was helpful in also predicting who might relapse and when to start treatment, because when you carry that antibody, even after your first event of a transverse myelitis, if you're positive, the likelihood of having a second event is pretty high. Of 9 positive patients, 5 developed a second event, 4 were recurrent, and 1 of 9 developed optic neuritis. And that's shown in this next study here, well, this survival curve here. You can see that the positive patients were at high risk of relapsing. So when we see that antibody in a patient, we treat up front aggressively to immunosuppress, because given that relapse severity, it's essentially like at any time a relapse could be devastating. In addition, the presence of the antibody predicted a worse visual outcome, the presence of a recurrent myelitis, and death. So again, we are very proactive of treating the presence of the antibody in a patient who's had a recent event. Dr. Lennon really led the discovery of the antigen, aquaporin 4, which really opened a window into cell biology in relationship to clinical disease like no other situation had in many respects. Maybe NMDA receptor encephalitis would be a nice parallel in that regard. But in any event, this particular antibody, when you looked at the immunofluorescence pattern, this is in brain, this is distal collecting tubules of the kidney, parietal cells of the gut. And what was apparent was this antibody was co-localizing here with aquaporin 4, but we knew it stained these 2 sites. And in fact, it was a Google search showing brain, kidney, parietal cells that emerged with the possibility that aquaporin 4 was a candidate. So it's the power of Google. I hear they're moving more of them to Seattle, I just heard. But in any event, what was also done in a knockout animal with Alan Verkman was we found that the knockout animal, the NMIGG, did not stain in the aquaporin 4 knockout. But it was important also to have molecular evidence, and using what was green fluorescence labeled aquaporin 4 cells, and then actually using a lysate and coming in with the antibody and looking specifically at what it pulled down. It was only the NMO serum that pulled down aquaporin 4. You have to know the complex consists of other proteins such as alsyn-trophin, beta-dystroglycan, and dystrophin, but it was specific for aquaporin 4. This is a pretty interesting protein. It's an osmosis-driven bidirectional water channel, and it forms these crystal-like supramolecular assemblies called orthogonal arrays of particles. And this particular aquaporin 4 exists in 2 isoforms, an M1 and M23 isoform, that has to deal with the relative distribution of that. It forms these mixed arrays on the cell surface and mediates water transport. It is found on all surfaces of astrocytes, but particularly in the polarized plasma membrane of the astrocytic end foot process in the CNS perivascular and peripeel end feet that are in direct contact with the basal lamina of the endothelium and the vessel and the pia mater. It's also found in the ventricular ependema, intraneuronal synaptic junctions. It's not found in neurons or oligodendrocytes. And interestingly, when you stain normal tissue with the aquaporin 4, just normal aquaporin 4, you can see that it causes this rosette and rim pattern reminiscent of what we saw earlier on in 2002 when we saw this pattern of complement deposition. So a clue that maybe we were actually targeting this antigen as well. This just shows you the polarization of where aquaporin 4 lives here. This is the peel cell, the aquaporin 4 at the subarachnoid space. And then here you see it in the Virchow-Robin space, polarization, and then the endothelial cell. And out here, not in near the lumen, but on this outer portion, again, where we saw that C9neo. It's a fascinating protein that is critical in regulating water flux between the blood and the brain and the spinal fluid that accompany potassium ion fluxes. It turns out it's co-expressed with the KIR4.1, which is involved in clearing potassium, as well as co-localizes with GLT1, or also known as EAT2, the glutamate transporter. So what's interesting about it, here you have this aquaporin 4 sitting in a central area that controls water homeostasis, potentially glutamate homeostasis, ionic homeostasis, central mechanisms in cell biology, the nervous system. We later showed that unlike MS, where you see actually an increase of aquaporin 4 in active demyelinated lesions, you do not, first of all, see the rim and rosette pattern of C9neo. You might find it in some myelin areas or within macrophages of pattern 2MS, but the IQP4 is increased in the active lesion. In contrast, this rim and rosette pattern here in the spinal cord, you see a striking loss of the aquaporin 4 antigen, even extending beyond the areas of the complement deposition. Thought I'd show an interesting case of a patient, 65-year-old, who presented with a tumefactive brain lesion, initially with a right lower field cut. This evolved, and I'll show you the enhancing left occipital lobe lesion, which extended across the corpus callosum. Her MRI spine was negative. They did a biopsy about 6 months in at the home institution and said it was demyelinating and called it MS. She had a normal CSF, prolonged VERs, was treated with glutarimer acetate, and then kept getting steroids for recurrent exacerbations of visual dysfunction and cognitive impairment. This was her MRI initially, and you see this pattern, which we now will learn is something we see, actually can see in NMO. There's a little enhancement, plus this kind of capping of around the ventricles. And again, here some periventricular enhancement. She was seen back 4 years later with new lesions on her MRI brain. They stopped Copaxone, they put her on Cytoxan, and they had sent me her brain biopsy to take a look and see what I thought. And what this shows you is her brain biopsy. This is a PLP, which is a myelin stain. So there is demyelination, but it's actually active demyelination. Many of these macrophages contain myelin debris. This astrocyte stain shows the presence of plenty of astrocytes, but a striking loss of aquaporin 4. And within astrocytes, within macrophages, you'll find astrocytic debris. This is GFAP within the macrophages. So this was suggestive of NMO, and we recommended she be tested. It was positive. They treated her with Cytoxan. I never use Cytoxan in NMO for a number of reasons we can talk about. But she didn't have her first real classic NMO attack until 4 years in. And I think it's important to remember brain lesions can be presenting symptoms. And the brain biopsy in this case was diagnostic, which prompted testing. Now we test before we biopsy, which would be worth considering in your differential diagnosis of a tumefactive brain lesion. We subsequently published the diagnostic utility in a cohort of surgical biopsies we had, 19 cases that were called active demyelination. But we noticed they had unusual features consisting of vacuolated myelin, lots of granulocytes, funny-looking astrocytes, and when we stained for aquaporin 4 in this kind of selective cohort, it was lost in the active lesions. So it's important to keep in mind, even at the pathologist level, that this could be in a differential diagnosis. And now Mayo's kind of added AQP4 to the routine testing at surgical biopsies because of this observation. It's a busy slide, but in the cohort we studied, notice 7 of our patients presented with brain lesions, and the X represents when they had their biopsies. None of them were carrying a diagnosis of NMO, some going as far as 2 biopsies 26 years down the road before the diagnosis was made. Another case was kind of interesting, showing you a little bit about the evolution of the lesion, which gave us some clues. This was a patient who presented with multi-level LATM a week after a herpes zoster rash. She was NMO-IgG negative, recovered, and then it was 3 years later, had a recurrent event, was now positive and treated with plasma exchange. Within 3 months, she developed cognitive difficulties and extensive cerebral and cord lesions to progressive vegetative state to death. Again, kind of looks like that last patient, but in any event, you see these wild lesions, large lesions, it's not too long of a lesion actually in the cord. Her brain, however, had so many lesions to study that it gave us a sense of some of the patterns here. This is PLP, the myelin stain, and note this area doesn't really show any obvious demyelination. There's lots of granulocytes and eosinophils in the infiltrates. The astrocytic stain is still present, but there's a striking loss, a widespread loss of the aquaporin 4 antigen. In some of the more advanced lesions, you can see you begin to kill off the astrocytes. There's many fewer of them. Not quite so many granulocytes, still the loss of AQP4. And in the advanced lesion, you'll see pronounced demyelination. Again, this is secondary, it's later, it's not the earliest event. Not as many granulocytes, still the AQP4 loss, but very unhappy astrocytes, swollen, looking bizarre, dying, fragmented. So this told us already from the microscope, eosinophils, granulocytes were present early, even before complement activation. It looked to be beginning around the perivascular region. It began to raise this concept of a sublethal astrocytic injury before the dead astrocyte. And I got very interested in that because I'm like, okay, if I get ahead of a dead astrocyte, maybe we can intervene therapeutically to prevent that from happening, because a dead astrocyte is hard to repair, although there are some transplant strategies looking at that. So what is the evidence that this is a pathogenic antibody? Well, first of all, let's for a moment talk about astrocytes and how cool they are. Basically, they do a lot more than just glue and scar the brain. They're involved in glutamate transport activity. They produce neurotrophic factors. secrete a number of important factors in synaptogenesis. They're key regulators of immune modulation together with the microglia. They regulate the blood-brain barrier. They're important in brain glycogen energy reserves. They regulate extracellular ions. They're important in the regulation of neurotransmitters. So it's kind of like, what do they not do? They don't myelinate, but they do a lot of these other things. I showed you that we do get dead astrocytes, so we recognize that's one of the endpoints of the NMO process. Again, showing the astrocytes full of the GFAP debris and these fragmented astrocyte processes that are all that's left in this field here. And it was shown that when you use these HEC293 cells where they're transfected with AQP4 and labeled green for the AQP4, it's only in the presence of NMO-IgG and active complement that you see the labeling on the surface where the aquaporin 4 is of C9neo, showing that you get complement activation. This was also done in a study that's called a propylium iodide intensity measurement, and really all you really need to focus on is that in the presence of active complement NMO-IgG only, do you get cell lesioning, lysis of the cells. Relapses in the prior year, and so now they're taking that forward to study in a phase 2 trial, but it did support a central role for complement. What was interesting also was if you look at aquaporin 4, it co-localizes with the transporter EAT2, not EAT1, but you see the co-localization. And when you took NMO-IgG and applied it to these GFP-AQP4 transfected cells, you get internalization of not only aquaporin 4, but also EAT2. So you're messing up glutamate homeostasis. When you look at the lesions, in the presence of a C9neo, here you see the C9neo, you see the loss of AQP4, and a striking loss of EAT2 as well. So they're co-internalized together, and there's evidence as well that this is impairing the uptake of glutamate within NMO-IgG, reduces glutamate uptake within the cell in vitro system. The other thing is that aquaporin 4 is kind of around the paranode. We showed evidence that it co-localized with Caspr1, a paranodal protein. So why is this also important is that the binding of IgG to aquaporin 4 can impact astroglial polarity, compromising end-foot membrane integrity, osmotic regulation, maintenance of the paranodal synaptic environment, glutamate homeostasis, ionic homeostasis. And all this is not unexpected to result in demyelination. It didn't begin with the demyelination, it began with these other processes. And then I'll kind of have the second half of the talk is really about all this reversible business and why I'm interested in that. So we see these destructive lesions, as I showed you, but we also see these non-destructive, non-demyelinated lesions in the brain. And we can find areas where there's loss of AQP4, but plenty of myelin around. It looks kind of vacuolated, but there's lots of microglial activation around this site. Granulocytes are often present early in these lesions. And this brings us to this concept of antigenic modulation, which reflects a functional outcome of when an antibody binds to its antigen. You see this in other autoimmune channelopathies. And what happens is it binds bivalently to adjacent cell surface proteins, cross-links them, endocytoses them, and then degrades it. But why is that important is because the antigen-bearing cell, in this case the astrocyte, is compromised functionally, but not necessarily destroyed. And that means there's a potential to intervene. And this was just a series of studies, both Shannon Hinson and Bogdan Popescu in my lab. But what we see here are these HEC293 cells. You put an antibody on, within 5 minutes it comes off the surface. And then you put fresh serum, normal serum on, and it can recover. This was shown to be isoform dependent, mainly M1 internalizes. And we also found evidence, both in the tissue as well, but it directly impairs water flux, which kind of probably explains some of the edema we see in NMO cases. What's also important is the aquaporin 4 loss of protein is not just due to dead astrocytes as most of the world thinks. There's plenty of astrocytes in this field, but notice the loss of aquaporin 4. We generate an in situ probe for messenger RNA and can see within areas of loss of aquaporin 4 that you still get a massive upregulation of the message. So those are viable cells. That's an important concept. And there isn't a brain astrocyte that I look at in NMO under the microscope that doesn't look bizarre. I mean, the whole brain looks like an overall astrocytic cytopathy of some kind. You see pronounced gliosis, unlike anything you see in MS. Look at the astrocytes here. There's mitoses, multinucleated astrocytes, and prominent Rosenthal fibers, something you see in Alexander's, but in this disease you see that in areas even of normal appearing white matter, likely a tombstone or a marker of a stress response. More importantly, we find that in areas that even have no complement, still have myelin and astrocytes, that you get prominent granulocytes very early on. And in fact, almost a quarter of the regions we analyzed showed marked granulocytes despite no complement there. We think that's important because it tells us it's not just complement activation that pulls in the granulocytes. There's something else going on. So we wanted to ask what is going on, and they're early and robust responders, and we asked what are the transcriptional and translational consequences of NMOIgG treatment on astrocyte function in vitro. We used our mixed glial culture system, both initially in rat and then in mouse, and what we find is, first of all, the NMO does stain the surface of the cells that we're using, so we're binding it and engaging it properly. And then we profiled responses via IF, microarray, ELISA, Western blot. We had published in GLIA that NMOIgG stimulates a really robust immunological response in astrocyte cultures. You can see just how high the fold changes in a number of these cytokines, chemokines, and also lipocalin-2. And then we recently published that, and this is Maggie Caulfield, who's just leaving my lab after 2 years as a postdoc, going on with a new job with her husband. And here we were also able to show that NF-kappa B signaling drives this response. First of all, NMOIgG stimulated a progranulytic profile in mixed glial cells, similar to what we saw in the rat. Look at all the cytokines and chemokines, and we'll look at those more closely in a minute. And you only see that with NMO, not with the control. This is just a higher power of some of those gene families. We found that NF-kappa B dependent transcription factors and stress genes were upregulated. See all these NF-kappa B factors upregulated greater than twofold compared to control, including REL-B, suggesting multiple NF-kappa B pathways are involved. And then we compared it to a published profile of reactive astrocyte genes from Ben Barris's group and compared the NMO group, and there's some overlap here. So then we looked at, with a hierarchical cluster analysis, comparing it to an LPS, what that does to astrocytes, middle cerebral artery occlusion, NMO, PBS, and control. And you see this upregulation within the NMO group, a distinct cluster with some overlap with the other two, but not direct. NF-kappa B showed the greatest dynamic change. So then we looked at this more closely, and we were able to show that NMOIgG resulted in accumulation of phospho-I-kappa B, suggesting engagement of the signaling pathway and translocation of P65 to the nucleus. And you can see here, within NMO by 30 minutes, increase in phospho-I-kappa B with decrease in I-kappa B. And you see it translocating to the nucleus in NMO, but not the control, but in the TNF-alpha positive control. We then measured the chemokine cytokines, and we saw that treatment caused a marked increase in certain progranulocytic chemokines, such as CCL5, CCL2, CXCL1, CXCL2, only with NMO. And then we started looking at the various pathways to try to block them. I won't get into all this detail, except there are a number of inhibitors that are available to block both the canonical and non-canonical pathways and CREL pathway. And suffice it to say, when we use these inhibitors, it blocked the translocation of P65 with the different inhibitors, suggesting multiple NF-kappa B pathways are engaged. And furthermore, we could block the production of the chemokines. This is fold inhibition, so longer means greater loss with the various inhibitors. So what this just tells us, a complicated schematic, but in addition to the antibody causing an impact on modulation, on glutamate homeostasis, on complement-mediated damage, you're also getting activation directly of NF-kappa B signaling, driving a chemokine response that is pulling in these granulocytes early, even before complement deposition. So then the last quarter of my talk is really on the spectrum of the disorders, really the animal spectrum of disorders being the tip of the iceberg. We all talk about opticospinal MS as being the hallmark, but in reality this is likely just a site extremely vulnerable to edema and swelling, and more than it really being the selective site. So I think in a way it kind of distracted a little bit our thinking, and pathology told us there was more going on. There's really an expanding spectrum. When you look at the positive antibody, including relapsing optic neuritis, LATM, brainstem syndromes, area postrema, which we'll get to, ADM and press-like syndromes, sleep disorders, SIDH, endocrinopathies, and on and on. So what's interesting MRI-wise, we started seeing these lesions where the aquaporin 4, this is where it lives, and you'd see MRI lesions exactly in those sites. And again, you can see these press-like lesions right around the ventricle and the thalamus here within the brainstem. And in addition to that, we were recognizing, as did others, that nausea and vomiting could be a presenting symptom. In fact, in a series, 75% of these patients were going to a GI doctor, vomiting for weeks at a time, this poor person up to 80 weeks. And then they would develop their optic neuritis or TM well after this presentation. So this is a video I can't show. Is a guy who was just really had intractable vomiting until he finally presented with an optic neuritis, and then they figured out, oh, this is probably NMO. Once they treated used steroids, his vomiting completely disappeared. We had looked at this pathologically, and when you drill into the area postrema, this is actually the area postrema. Look at the loss of AQP4. Here there is complement, but the loss of AQP4 here. And in fact, you can find nausea, vomiting, intractable hiccups on almost half the cases. Just ask them about it and they'll tell you. They don't always volunteer it. This was a patient, 13-year-old, who presented with nausea, vomiting 3 months before their optic neuritis. They didn't get tested for NMIGG until they had an LATM. But look down in here and you can see the gadolinium enhancement literally in these little eyes looking back at you. That is the area postrema. Look back at some of your patients. You might be surprised how often this very subtle finding could be present in the patient. And this is very interesting because in the area postrema, like the other circumventricular organs, they lack a fenestrated barrier. So they have a fenestrated barrier, so they lack a tight endothelial junction. So that could cause diffusion of large molecules such as an NMO-IgG or circulating IgG. And we think this is one access point from the periphery into the CNS. And these are often reversible lesions, and it's likely that this is a site with large amount of aquaporin 4 that can eventually overcome the NMIGG binding. We looked at this in autopsy series, just happened to look how many of our cases of NMO who had died had lesions within the area postrema, and we saw it in 6 out of 15, saw the loss of AQP4, never seeing this in MS or our controls. The other thing we've seen is leptomeningitis. So your patients get treated thinking that they've got meningitis, and lo and behold, boom, they have NMO. This was a lady with optic neuritis, again optic neuritis, a high titer, and NMIGG. She then presents 2 months later with dizziness, nausea, headache, nuclear rigidity, low-grade fever. She gets diagnosed with an aseptic meningitis, 109 white blood cells, and she gets readmitted 10 days later, and by the next day she dies of acute respiratory arrest, has pronounced edema on head CT, no other lesions elsewhere, and she just had widespread diffuse and patchy lymphocytic meningitis and perivascular cuffing in the gray and the white matter. So we looked at meningeal inflammation in our NMO cohort of N of 24 cases, and those with meningeal tissue we analyzed carefully, and suffice it to say there's a heck of a lot going on in the meninges of NMO. Many neutrophils are present, many eosinophils, as well as plasma cells are in here. You even see this in the Virchow-Robbins phase, an eosinophil kind of tracking here down within this penetrating vessel. Here's an infiltrate again of eosinophils and plasma cells. And just like the bone marrow, it turns out eosinophils and plasma cells like each other. It creates a rich niche for plasma cells. So it might account for why you could have persistent plasma cells and continued attacks in the setting of rituximab, because that will not target the plasma cell. It'll only get the CD19 cells. We don't find, unlike MS where you see these meningeal follicles, you do not find any evidence. You find infiltrates, these are B cells, but no obvious follicular dendritic cells or something to suggest it's a follicle like in MS. So this infiltrate is compatible with the progranulocytic chemokine environment in the brain, as well as what we see in the CSF. We don't see lymphoid follicles. And it's important that meningoencephalitis be recognized as an initial manifestation of NMO. And we've seen leptomeningeal enhancement on MRI in NMO cases. So we think it's a prominent observation occurs early in the disease. This just shows some of the enhancement also along the ventricular region. And you can see around those that first patient, and here's another patient with this kind of periventricular white matter change. We've been able to see a unique ependymal pathology in NMO as well. This is normal, this is MS and NMO. I know it's complicated, but for a moment, let's just focus on the fact that in normal, you don't see C9neo, you see lots of AQP4. In MS, lots of AQP4, no C9neo, a few microglia. And let's come into NMO, and we find not only do we see this vacuolated area just below the ependyma, but you find some microglial activation. You see the loss of AQP4 selectively, and you can also see C9neo in the ependymal cells, and these do express AQP4. We also see this wild peel pathology. Here is the peel, and you can see here specifically normal MS NMO. Note the microglia are here present along the edge of the pia. You don't see it in the other conditions. A selective loss of AQP4, unlike what you see preserved in MS and NMO, MS and normal. And only here do you see the C9neo along that peel surface. Finally, we just published recently that you can see hydrocephalus in NMO. And you ask yourself, why hydrocephalus? Turns out we were the first to see that there's actually aquaporin 4 within the normal brain here. It hadn't been described before, said not to exist. But here's clearly aquaporin 4 in the choroid epithelial cells. Selective loss in NMO, some focal C9neo staining, and you actually don't get the loss of aquaporin 4 in papilloma controls. So we think this could be contributing even to the hydrocephalus that is shown to be more frequent in NMO compared to the general population. So it's a complicated picture, but what it's really telling us now is let's think about where aquaporin 4 lives. And what this is going to show you is where it's living. And basically, in the choroid epithelial cells here, you can appreciate that this is a fenestrated vessel, which means there's potential for aquaporin 4 NMO-IgG to get in and bind here through this fenestrated vessel, just like it can do in the fenestrated vessel of the area postrema and the circumventricular organs. So you have access of the antibody to the antigen in the CNS. In addition, in the peel surface, look at the astrocyte input processes. It's conceivable through the spinal fluid. You lack tight junctions that it could access to the antibody there. In addition to that, you can see here at the perinodal region and in the non-fenestrated vessels, eventually, once the barrier is open, you have now access to these other sites. And there's a very interesting literature on the role of aquaporin 4 in the lymphatics, but you have communication of the interstitial fluid with the CSF. So now you have access and opportunities to propagate this disease process widely in the brain. And then finally, this concept of a systemic disease. Aquaporin 4 is also in the olfactory epithelium. Cases of anosmia. We had a patient who had anosmia, and then it wasn't until her third plasma exchange she could smell the alcohol as they were hooking her up to the plasma exchange after she was being treated. Cases of sensory neural hearing loss in NMO, and again, aquaporin 4 is also present within the inner ear. It's also present in skeletal muscle in the sarcolemma. And we published the first case of an aquaporin 4 seropositive patient with recurrent hypercikemia, now described as well in NMO. A number of cases with sky-high CK, not really that symptomatic, nothing so obvious on biopsy until we looked and saw a couple things. This is normal dermatomyositis and NMO. We found eosinophils and granulocytes within the NMO, and only in NMO did we see the deposition of IgG and C9neo in the sarcolemmal area, and we saw the selective loss of AQP4 in NMO. Here you see at high power. It was actually present in normal and in the dermatomyositis cases. So here, extending for the first time aquaporin 4 myopathy beyond the central nervous system. So my last slide, this is kind of an older slide. It's since kind of just telling you where the field's looking at. Yes, people are inhibiting complement. Yes, they're attempting to block the binding to aquaporin 4 with the monoclonal antibody. We'll see. I have concerns that that could actually trigger a number of astrocyte responses. People are looking at how to reduce AQP4 expression. We know acutely the role of plasmapheresis and steroids, immunomodulatory agents to try to block the B cells producing the plasma cells that make the antibody, strategies to block the granulocytes and the inflammation. But I would argue that we really have to be thinking of neuroprotection of what is really a widespread sublethal astrocytopathy. What can we do to interfere with the activation of astrocytes? Is that a good thing, and when? Because a lot of what they're doing is protecting the nervous system, so we need to understand the dynamics of that. Is there a role? The beta-lactam antibiotics in ALS were really intended to stimulate expression of the glutamate transporter. Would that be a beneficial role? What about transplantation strategies? Again, these are all speculative things, but I think we need to be thinking about NMO not as a disease like MS, not modeling it like MS, but modeling a unique disease with an opportunity to give us really tremendous insights into the role of aquaporin 4 in the human body. We have a comprehensive program at Mayo looking at NMO with our team, and I just want to kind of recognize the people of our group, Dr. Lennon, Dr. Weinchecker, Dr. McKeon, Wingerchuk, Pittock, Howe, Owen Flanagan, and Bogdan Popescu, who we work very closely across this group, this multidisciplinary group. These are people within my lab, these are my technicians in the lab, and Young Guo is a really phenomenal pathologist working with me, as well as Maggie Coldfield, really doing a lot of the basic science work, and now doing some imaging work as well. We've been looking at glutamate imaging and MRS, 7 Tesla MRS in the cases of patients with NMO, and Josef from Hans Lossman's group worked with me, and of course my husband and my kids. So with that, I think we got plenty of time to answer questions, but hopefully I've given you kind of a sense of the broad spectrum of what's going on in the NMO world. I think it's really exciting, and I would encourage anyone with an interest in glia to know that this area is wide open for an opportunity to study. And I often talk about NMO as being like a conditional knockout in a human. There are patients with the antibody periodically giving us a clue to the role of glia in clinical disease. So thank you very much. So, questions for anybody? Or thoughts?
It's fantastic. So, aquaporin 4 knockout animals.
Yeah. What do they do?
They mimic?
They get hydrocephalus, actually. They've mainly been studied from the standpoint of their response to edema. They have problems with edema, so tumors in those animals get more edematous. They can't regulate the water. They do show some kidney pathology. I can't remember exactly what it was, but they don't show they don't really mimic the disease in this way. What would be interesting, though, is, from the standpoint of the astrocytes, how they respond to stress in the setting of aquaporin 4. So nobody's really taken those knockout animals and, for example, driven them in other stress areas. I do believe in stroke. I think they're bigger. The stroke areas are bigger, so they've done some of those types of things. They don't repair as well. It turns out aquaporin 4, apparently once it's gone, you kind of need it to set the scaffolding, I guess, in place. And so it's been said that the loss of aquaporin 4 also results in less remyelination in some of the models where they've tried to look at lysolecithin in aquaporin 4 knockouts. But they aren't really as helpful in being able to study some of the things we're interested in, but they do give us insights about aquaporin 4 when it's completely gone. They're well compensated by other things, syntrophin, for example, and so that you don't end up taking out the whole complex. So the dystrophin complex, dystroglycan complex, is still present. So,
a very nice talk. I've seen a couple of patients with spinal cord lesions in NMO who were misdiagnosed based on EMG, with one patient with motor neuron disease and another patient with polyradiculopathy. And presumably there's some involvement of anterior horn cells at the level of lesions. Is there much known about that? Does that come up?
So yeah, I forgot I'm supposed to restate the question. I just realized. So I think I understand your question is in the cases who had NMO but were misdiagnosed as anterior horn cell disease or a polyradiculoneuropathy, how can we kind of account for that? It's not, in terms of the lesions themselves, they take out the anterior horn cells if you have a destructive lesion. So that could be one possibility. I haven't been struck by a lot of peripheral nerve pathology per se in this disorder, so I don't have much to add to that. I suspect it's just the pronounced areflexia coupled with the loss of motor neurons related to the destructive lesion, but I think it bears worth looking more carefully in terms of that question. Oh, yeah, I've got them. Okay, let me answer. Sorry. So, does NMO ever complicate recovery from other brain injuries? say due to infections such as herpes. Well, that's an interesting thing. The herpes encephalitis, people are beginning to report an association of herpes and NMO, and herpes simplex type 2 has been seen. Herpes zoster, I gave you that case. I just even presented you a case of zoster. We had another patient with an active zoster myelitis who literally concurrently with that infection developed NMO. So the question I have is the infection the reason that the barrier opened, and this was a patient predisposed to NMO, and then that antibody could now freely get into the nervous system is one possibility. Is the fact that the infection breaks tolerance in some way, and now you expose the aquaporin 4 in a susceptible individual, and they start generating antibodies too. That could be another mechanism. But we have seen it, and not only just with the herpetic infections, it's been seen with a number of other infections like schistosomiasis. One of the earlier reports was with tuberculosis. So, and it's been reported with the HPV vaccine. Somebody had described that. So it may be that these are people at the time that they're getting that infection, they might be at a state where their antibody is very high, and now you're getting access in. But it's uncertain. And then another question was, about 20 years ago, I followed a young man who carried diagnosis of NMO based on a Mayo Clinic biopsy of a high cord lesion. He had minimal residual and had no further episodes during about 10 years by his previous neurologist. He was never on beta interferon. I know this patient because that's actually my patient. I remember seeing that patient. What is your perspective? And I believe we said on this particular patient, he was rock solid for 10 years. We went back to his myelitis when he had the biopsy, and yes, it looked like NMO, and he did carry the antibody, but he was completely quiet, and it was one of those exceptional circumstances where we elected to observe as opposed to subjecting him to the risk of pronounced immunosuppression having gone 10 years. We did, however, feel like the slightest hint of any kind of neurologic problem would warrant coming forward with more robust immunosuppression, because it's not without its side effects. But it does raise and beg the question, why aren't all our patients getting all of these symptoms all the time? Why isn't everyone having nausea and vomiting if you've got this antibody around? And I don't know the answer to that. I don't know what the dynamics are about the flow, the access, the affinity, the avidity of the antibody, the fluctuations, the other hit. We talked about double hit scenarios. What else is needed to trigger the relapse isn't entirely clear. But this is a relapsing disease, and I think I'd be very, in a very exceptional case, ever think of benign NMO, because we've also seen they go 20 years and suddenly they get a flurry of attacks, and their attacks tend to come in clusters. So we just have to be careful with this guy, very vigilant, and at the same time, for the most part, when they're positive and they've had an event, a recent event, we're pretty aggressive about treatment. I think there was another question.
There's been some report about a link between NMO and myasthenia gravis.
Yep.
And maybe even triggered by thymectomy.
So we do see that. So the question was the relationship of NMO and myasthenia, and in fact, the prevalence of NMO is there's 2% prevalence of myasthenia gravis in NMO, and I do recall that report of thymectomy and then the patient developing NMO. It's likely a co-occurrence of autoimmune diseases, just like pernicious anemia is more common in myasthenia, NMO more common in myasthenia. But there are some interesting theoretical things, and it's well outside my expertise, about agrin and the role of agrin in myasthenia at the neuromuscular junction and within the dystroglycan complex, and could there be overlap or homology between these proteins that could be driving it? That's totally speculative. So at this point, though, you do have to be mindful, and including to your patient that had the polyradiculopathy, was there an overlap of another problem as well? So there was a question. Did you have your hand up? No, maybe not. Sorry. I'm sorry.
Oh, I wasn't sure. So you make the diagnosis of NMO.
Yeah.
What do you do next?
So you make the diagnosis of NMO, and they're typically symptomatic. First, if they're in the midst of an attack, you're extremely aggressive with the attack therapy. So you begin with steroids. We use high-dose steroids, but I have a very low threshold on a severe attack to begin almost plasma exchange almost concurrently. They're very responsive to plasma exchange. And the key is on a cord attack to be as aggressive as quickly as possible, because the edema in the cord is so significant that your secondary ischemia from taking a compartment that's swelling is so at risk that you have to get in there quickly. So that's why the numb finger or the I'm a little itchy across my abdomen NMO patient is immediately treated very aggressively. And similarly with the optic nerve. So we use plasma exchange and we use steroids up front, and then you put them on immunosuppression. And so your options really include, at the current time, most of us use Cellcept, azathioprine, or rituximab. I typically will use Cellcept as a first step, as my first line, and I will reserve rituximab for the patient who's had either multiple attacks or pretty significant brain lesions as well. And then we do use azathioprine as well. You just have to watch the MCV and make sure they're have a macrocytosis. Otherwise, we often end up finding that azathioprine is being not enough is being used, and they break through that. And then, now people are looking at a number of other therapies, blocking IL-6, and I would argue that almost any therapy right now that's going to block inflammation will get you somewhere, and we get pretty good. About 80% of patients will be stable for long periods of time on pronounced immunosuppression, like myasthenia gravis. But the breakthrough that occurs can be so significant and devastating that this is a disease that needs a home run. And I do feel that spending too much time to play around with anti-inflammatories and immunosuppression is only going to get us so far, because it's still downstream in the cascade, which is why the upstream neuroprotective concept and treating kind of the astrocyte hyper-stressed response is a possible another venue to consider treating. We have other ideas, too, about what could be done as a protective strategy.
And if you have a collection of cases with a clinical diagnosis of transverse myelitis, do some of them turn out to have NMO?
Yeah, there'll be the key thing is if you have an LETM, a longitudinally extensive transverse myelitis, so extending over 3 intervertebral segments. But we just had a report in neurology, I think, about small lesions as well, so that doesn't exclude the possibility. But at the moment, most of us will check an NMIGG in TM cases, just to be sure we're not dealing with it. We'll also, in patients with unusual presentations of brain lesions, press lesions, we'll check NMIGG before obviously putting a needle in the brain, if we can help it. And in those circumstances, if they're positive, we'll be likely to treat. And then we'll do a malignancy screen for a patient who's older, who's getting NMO seemingly out of the blue at age 65, and now you're wondering, well, where did that come from? So we will do a paraneoplastic, a screen for cancer. And right now we have a cohort of about 14 patients where I have the tumors. We're all paraneoplastic NMO, and a subset of those tumors do express aquaporin 4. We had a case published in a carcinoid that relapsed and then developed NMO at the time of the relapse. The carcinoid heavily expressed AQP4. Not all the tumors express the aquaporin 4, so trying to understand that whole paraneoplastic immune response is complicated. I don't fully understand it yet.
So you're talking about early upstream events. What's most upstream is the development of the anti-aquaporin.
Well, sure, that would be the...
So just out of curiosity, has anyone been able to figure out what are some of the triggers for developing those antibodies in the first place? Environmental risk, things like
that. Really interesting. We don't know what causes people to develop the antibodies, but there's interesting things to speculate about. I've always been fascinated by the fact that now this is me just speculating on it, I don't have any evidence to support this, but so parietal cells in the gut express AQP4. When they're exposed to histamine, they change their isoform. They alter the expression of aquaporin 4. It has, in my opinion, the potential to become immunogenic. And so it could be that there are certain things, if you look at where NMO lives in underdeveloped countries in Africa, Asia, is there something about a parasitic response? You have a response in the brain that makes it look like it thinks it's a parasite. Why do I have all these eosinophils in my brain? Almost nothing causes eosinophils to come in the brain except a Florid-Sturge-Strauss vasculitis or a parasite. Something about it seems to me that it's striking as a potential parasitic trigger, or the brain seems to think it's a parasite when it sees this. So I don't know what causes that to occur. The other potential is, yes, tolerance could be broken in the central nervous system first. However, we typically find less oligoclonal bands, which makes you think the antibody is being generated in the periphery as opposed to centrally, like NMDA receptor encephalitis. So I think tolerance is likely broken in the periphery. Vanda thinks cancer is a big trigger. She thinks almost all of these are paraneoplastic, and that, in fact, you just haven't found the malignancy that's producing the cells that produce the antigen, and that with the destruction in the tumor cells, that could liberate antigen and cause a response. I think the paraneoplastic immune cases, NMO cases we've seen might support that, but we don't find cancer in everybody. So there might be a number of ways in a susceptible individual, but I don't know We're probably at the same place where we are with myasthenia gravis. I don't know why they start getting those antibodies. But it's interesting, and we need to kind of, the immunologist, the hardcore immunologist might be able to help us with that.
You were going to say why you don't use Cytoxan.
Yeah, so Cytoxan will drive eosinophils, will drive a Th2 response. And the last thing I want to do is drive a Th2 eosinophil response into the nervous system, considering the amount of eosinophils I've seen. And I've seen anecdotally paradoxical worsening with Cytoxan. So I typically don't use Cytoxan at all here. I will use it in aggressive MS when I'm sure it's MS, and I don't think it's NMO or an infection. But in this case, it's just a drug that it's anecdotal more than anything.
We know about the pathophysiology. How do we explain the NMO IgG?
Yep. So one thing is we've seen that it may sometimes takes time to develop the antibody. I thought that herpes patient was interesting. They started out negative, then it was after their herpes that they became positive. So that raised the question that was that the trigger in the patient? I don't know. I suspect part of it is detection. No test is perfect. Part of it may be treatment for some patients that it drops the level. Part of it could be another antigen, kind of like the whole Musk story in myasthenia. Maybe there's another antigen within that complex, but it increasingly represents a smaller part as the assays have improved. So we're probably, although I said 76, we're probably even up to closer to 80+% are positive. And it probably could be explained, a number of, all three of those could account for the next 20%, of which probably a very small percent could be another antigen. We even had cases of genetic shared NMO in a family. And there was questions about whether there was a mutation, a SNP, functional SNP, within the M23 portion of aquaporin 4 in that patient. Is there a genetic form of NMO? Not so obvious, but it's strange to have these two sisters both get NMO, and all the DNAs we looked at, it was the only ones that showed this abnormality. It wasn't me, my work, that was the work of Brian Weinschenker. That's right.
I have a question about the hydrocephalus that you
Yeah.
mentioned, because that should involve the CSF outflow pathway. So if you
Both.
look at the arachnoid or in the animal models, the lymphatics through the olfactory,
Yeah.
because that's where a lot of the CSF goes
Yeah,
out of the
yep.
animal models.
I'm really interested in that. I haven't yet, but I'm particularly interested. We're now recently started looking at trying to get the interstitial fluid, first of all. So we were actually have this strategy. We just were able to squeeze literally the brains and then quantify. In the animals, we NMO IgG tested, inoculated. We found sky-high LCN2 and the progranulocytic chemokine, suggesting we were accessing the interstitial fluid. It's what we were looking at. But to your point now about, I think that the cervical lymph nodes, as well as the nasal mucosa, are two sites to interrogate in this disease. And I think we might get further doing that than trying to make a mouse with astrocytes that look nothing like the human astrocyte, that are far less complex and multifunctional than the human. I don't know how far we're going to get there on that side of things.
Yeah, and you may want to take a look at the arachnoid. Deb Grzyskowski from Ohio
Yeah.
State has done a lot of work on the role of the arachnoid
Yeah.
in regulating the CSF.
Yeah.
So
Yeah,
that
and-
may be another place to look.
Yeah, that's interesting, particularly with some of the recent work, right, of the lymphatics within the dura and that. So I think it and how important aquaporin 4 is to clearance of the interstitial fluid through the lymphatics. I would also wonder, and I was wanting to test for this, is whether we see elevated A beta in the spinal fluid. Do we see other clues that we have a disruption? Is that a potential biomarker to interrogate the status of the brain in a different way than waiting for someone to blow out their spinal cord? That's kind of the direction we're going with some of this, but it's a good point. It's interesting. Yes?
Yes, is there much experience yet on bone marrow transplant for refractory NMO?
I know there's a couple where someone else could maybe know better than
We
I.
have done a couple actually here.
Oh, really?
Yeah, you guys are the bone marrow place.
What's that?
Yeah, you're the bone marrow place. You guys do.
We have done a couple of cases that have done really well in our neurology transplant group.
I think it's hard to know, because of the clustering that happens of attacks in NMO, it can be real, and you pronounce the immunosuppressed in the transplant state, but it'd be interesting to see to what extent you fundamentally reboot. Did they go negative after you did the transplant?
They did, but I think we need more long-term follow-up.
Right. Yeah, it's interesting. How about any other questions? Well, this was fun. Thank you very much. Appreciate the invitation.